remarkable work to advance the quantitative study of racism and discrimination, instructional for violence writ large. Abigail, we're really happy that you're here, and we look forward to hearing your ideas.
Well, I won't give you only stories today, but I am a bit of a storyteller, and I have a problem figuring out which one to start us off with today is Chicago. Chi-town, what's up? All right, West Side, what's up?
South Side.
Okay. So I guess I don't have to tell y'all these stories. I'm gonna tell you one though. It's not from Chicago. I do apologize. I'm not gonna be able to project too much.
Where are you from?
I'm from Atlanta. Well, they tell me I'm from Atlanta. I don't think I'm from Atlanta though. The West Side of Chicago, what's up? Well, I found myself on the West Side of Chicago in, you want to tell me? I can't tell you stories right now. Well, we gotta go back now, 2002. I came down, I was working for a publishing company, don't ask me why. I'm an engineer at the time of my life. I wanted to be an engineer. I wanted to save the world. I wanted to cure cancer, and I thought that following plastics and metals and energy would help me do that. So I was on that journey down working as a research assistant at the University of Florida. But they didn't let me into a program because I was too young. I had to come back home. When I came back home, I hooked up with some writers. I was a poet sometimes, trying to be. And they had a network of people, women, who created all kinds of energy on the south side of Chicago, and ended up doing my thing. And I thought it was half good, and I said, okay, I might be a poet. I might be a writer. I don't want to be an engineer anymore. But how do you save the world if you're not touching people's bodies? All right, so it really perplexed me. So I kept coming back to Chicago to figure out how to do that. I ended up writing a dissertation using data from Chicago, one of the first data sets to sample neighborhoods. And I kept coming back to Chicago. All my people left Chicago. I was like, what's up? Why everybody leaving Chicago? What's going on? Gentrification. What's going on? Urban redevelopment. But these are stories that were going on all over the country. They were going on in Brooklyn, in DC, in Atlanta. They were going on in Oakland. Every place I went when I was looking for black people, for African diaspora people, for queer people, for people who were doing the work of healing people, not necessarily with medicine, but through words and art, they were leaving. And I didn't understand what was going on. So I kept chasing Chicago in a lot of ways. But it started here in 2002. Windy City Black Pride, they decided I was half a good poet. Not the best one, but half a good one. And that helped me understand who I was in this world. So I'm not gonna tell you a story of Chicago, because I think y'all know Chicago, but I'm gonna tell you a story of Lancaster, Pennsylvania. All right. His name is Sean, and he wasn't doing anything really, but he just happened to be in the area, and he happened to fit the description. There happened to be some gunshots that went off, and they happened to think it was him that was firing the gunshots. And these people didn't even get out of their cars. They didn't even get out of their, what I would say, their apartments. They simply called the police and said, hey, we think there is someone here trying to kill us. And someone believed them. And it's not a joke anymore when I say that I believe calling the police on a black person or a person in an urban neighborhood that is predominantly black is almost a death threat. It's almost a promise. Because when they showed up, he was not the person they were looking for, but he was on the street. And they told him to sit down on the ground. And he sat down on the ground. Mm-hmm. And they told him to put his feet forward, and he put his feet forward. And you can watch the video. Mm-hmm. There's a video. Sorry. They told him to stretch his hands up. He stretched his hands up. And they still tasered him with 7 seconds of orders, do this, do this, do this, and he did everything they told him to do, and he still became a victim of police brutality. That's what I would call it. All right. So I'm going to bring to you today a collection of studies that I've done, which I am entitling The Illness of Surveillance. And I am referring to a particular type of surveillance. It's not any type of surveillance. It's not you looking for your neighbor. It's not you looking for your dog. It's not you looking at your kids. It's when institutional gatekeepers are called upon to make sense of an uncertainty that is experienced in the community. Now, sometimes those are specific calls, like the ones I just talked about, and sometimes it's happened at such a level, a concentration level, the problems, quote unquote, in the community, that they just have a whole structure of surveillance set up to catch us. Sometimes before they even know that we are actually a suspect. One of the things that we find out by following this system of laws that has pulled around proactive policing or aggressive policing, I just call it police surveillance, institutionalized inequalities in surveillance, is that if you look back at the very beginning of these laws, the Terry laws, they were black men. And very little people talk about that, how what we think about what is suspicious behavior was codified on the backs and the movements of black people and blackness. What is furtive behavior? I don't know. I mean, sometimes I'm in South Bloomington, South Central Indiana and Bloomington, I feel a lot of furtive behavior going on, but those bodies are not black bodies. I feel very scared, but people don't count that as a condition upon which we will send out a state-sanctioned gatekeepers, the criminal justice system, the first line of defense, supposedly, to the state. And tell you who really is the suspect, regardless of whether they're right or not. It's not about whether you're right or not. It's about what the perception of innocence is and the perception of suspicion. All right. And most of the time, when you look at this picture, we focus on the people who are the victims of police brutality, of police violence, of police surveillance. We do not focus on. We kind of think of her as an artistic in a construct. I'm gonna focus on her. There's somebody who's left behind in these communities where people are targeted. I'll say the word targeted by state-sanctioned agents of criminal justice system. What happens to her? Who does she become? What does her hypertension levels look like at the age of 25? What does her further behavior fall? What category does it fall into when we think about all the different ways we can think of suspicion? At the age of 16, 12, we're finding in these data sets people who are targeted by police as early as the age of 8 and 9 multiple times. They don't care what age you are. They just care if you fit the description. All right? Frankly, they don't even find out what age you are until they actually book you. Let's be real. All right? So they are making assumptions about who you are, what age you are, not necessarily knowing what that is. All right? Most of this data does come from New York City. There are some other data sets that are popping up that have the level of dimensionality to it to understand what's going on with institutional gatekeepers, but New York City still has one of the best data sets that comes from the administrative sources. This is from the police themselves. This is police saying, I did this, I stopped them. Yes, I did. And being held, quote unquote, accountable for what they did. Now, much of you look in the literature, most of this research is actually grounded further into the criminal justice system to people who actually are identified by another agent of the system, a judge, as actually a criminal. Not a suspect, but an actual criminal. And what we find when we trace this literature to identify what the health risk, what the health outcomes, mortality outcomes even, of individuals who have been incarcerated are, we find that some peculiarities start to pull in. As a matter of fact, when you're in the system, you actually are protected from alternative sources of disease or causes of death, they call them, that people in your age and gender bracket will face. Gunshot. All right. infectious diseases. You actually are not dying of those things because you're in the pen, all right? But once you're released and you get on probation, you get on some form of parole, or you're completely released and you're not being surveilled anymore by the system, your mortality risk actually rise, all right? If you are formerly incarcerated, you actually have more health problems, morbidity issues than those who are in the system. Now, we can ask a question about why that is. Please ask your question, not right now, but later on. If you are someone who has a parent, you're that little girl, but your parent is caught up in this system somewhere incarcerated, your health outcome is much worse than other kids whose parents are not incarcerated. If there's someone in your family, a cousin, an uncle, a grandmother, a grandfather, who've been caught up in the system, compared to those who've had no one in their familial networks in the system, you have worse health problems. We're talking mostly about children now, also young adults, all right, where most of the literature has been on this. If you, and this is really where more of my research starts to come into play, but these first, the second and the parental or familial suggests that there's a network effect that's going on, not simply if you have direct contact, but if someone you know and you're connected to has direct contact. Well, we know that network effect also extends to people you do not know, you are not by blood connected to, but they live in your neighborhood. So they were from your neighborhood and they got locked up. If you live in a neighborhood where the incarceration rate is very high, you are more likely to have things like asthma. That makes almost no sense. Asthma has nothing to do with incarceration. Or does it? You start to talk about the distal risk factors, okay, of illness and disease. If you live in a nation, US versus Canada, let's keep on with the comparisons. But if you look at a nation that has a higher incarceration rate, and unfortunately the US is extreme here, but if you look at the lower end of that spectrum and you compare incarceration rates for nations that have higher likelihoods, I wouldn't say really likelihoods, but the density of individuals per the population who are locked up, you are more likely to have illness anywhere in that country, no matter who you are in that country. And if you one of the ones that's likely to be locked up or not, or connected to them, you in the nation, you part of the risk factor, all right? So we start to get more and more away from the immediate exposure of risk, which is incarceration, to people who are exposed to the system of incarceration, and I'll add the system of surveillance. We can talk about this from an even larger population level of people who fit a social status or political status, minorities, Black and Latino, indigenous peoples, as well as people who are impoverished or who have a history of impoverishment in their families. They're more likely to have higher rates of illness if those people in those networks within that social status, these are not people you're biologically connected to despite genetic arguments about race and gender and class and so on and so forth. All right, these are people who just happen to fit your description in some form or fashion. All right, and lastly, we have this question of a feedback that starts to happen when there are lots of people who are being incarcerated, being surveilled. What happens to them when they are released? Even thinking about the impact that they have on federal mandates in the healthcare system. Because now we have the healthcare system that is governed by the state, literally. It is the state, all right? So we know here from the literature, is that from incarceration at least, is that there is a fairly thorough relationship, and it's multidimensional. It doesn't happen all the same way. It's particularly poignant for people who have been released, people who are connected to those who have been released if they're younger in particular. It changes their entire life trajectories around how they experience illness and so on and so forth. But we start from thinking about incarceration and really the criminal justice system, and really let's go back, the first gateway into the criminal justice system, which is policing, from two different perspectives. And we're really capturing a linear way of reanalyzing the role of police in health, in public health in particular. First, when we first looked at police and public health, we looked at them as first responders to violence, trauma. So they were trying to help, so to speak, the people who called, right? Or even the people who were the victims, even if the people who called weren't the victims. But they were first responders, right? And it was a very organizational model, thinking about which type of police and who they were connected to in their own lives, how they responded to victims of violence. And so we really had a system of care model for thinking about policing and health, right? We weren't really following, we were probably at this point in time even very concerned with the health of the police themselves. And some of that research still goes on. A lot of that research, but most of it's in criminology now. We moved in the 90s towards thinking about it from a psychological model of thinking about the act of policing from the perspective of the respondent who we were surveying. So we start to think about policing if you experience a police encounter. So if police stopped you for a ticket, or they thought that you were a suspect, or even if you actually got arrested and so on and so forth, that is a stressor, right? Now, most of the time, how we're looking at stressors are acute in acts of I'm not gonna say trauma per se, but some form of along the line of trauma. We have moved more recently in the 21st century to thinking about police brutality. The system of policing as a brutal system, right? A system that actually produces hurt. It produces violence on the people that it should be protecting, right? Here, you're looking at a more chronic way of thinking about policing as a stressor. It's still a stressor, but a stressor is coming at the community level, it's coming at the system level, it's multidimensional, it's flowing through many different levels of the criminal justice system, but more and more, it's something that everybody lives with all of the time. It's endemic, all right? So first we start to think about the intended consequences of policing, and we move toward thinking about what we say are unintended, but some, if you take a more critical view, would say that even the brutality is actually intended, right? And we might start to have some conversations about how we should measure that. We're looking here, this is what I was talking about before, where you see a protective effect of those who are in local jails or state prisons, but higher rates of mortality. This is all-cause mortality for individuals who are in probation, or people who have been paroled. For probation, or people, they may have, they're not gonna actually book them into the system yet. I mean, that's probably like the precursor to the jail. You hit probation, or you have a violation during probation, and you become meat meals. Right? Now we have to talk about meat meals and parole. It's a very different kind of conversation, right? Before, when he was probation versus now he's parole, right? Or his life is like parole. I want to say that's exactly what's going on, because he is fighting all of those things. But we still have this issue of what happens. Most of us will be concerned with what happens to meat meal. All right, who's concerned with what happens to meat meal? It's Chicago, but I know there's some Philadelphia people here. All right, just one. Dang, that's bad. Just one. I'm concerned about what happens to meat meal. I spent some time in Philly, so I gotta have that empathy level going there. So we want to know that somebody knows an imprisoned person. A lot of people in Philly know imprisoned people. All right. We know that particularly black men and black women who are more likely to know imprisoned people, that network effect. All right. We're more likely, black men and black women, particularly black women in particular, have family members who are in prison. All right. Then we can think about this from an even more distal perspective of the neighborhood. Black men and black women in the yellow here are much more likely than their white male, white female counterparts to know someone a neighbor who is imprisoned. All right, now that doesn't mean that you have that neighbor is your friend, but they were down the street. All right, and then the more perceptual question is of whether you trust someone who's in prison. Well, if we think about who the imprisoned person is supposed to represent in society, someone who is locked away from, is not benefiting society anymore, has harmed society, why would you trust an imprisoned person? Either you don't believe that is true, that narrative too, or you don't care, right? Or you care about the person more than you care about the system, or the people they hurt. Or it may not be that complicated, or it may not be that simple. Maybe you care about all the people, and you still believe that there is sometimes we call it restorative justice, rather than what we are doing now, which is very, very, I wouldn't call it precarious per se, but it hurts people. It hurts the people who are in prison, and it's designed to do that on purpose, assuming that if we hurt them enough, that they'll do better when they come out, which is odd, but that's what the perspective is. Now we know that within this surveillance system, that we actually have some trends to suggest that police surveillance itself is actually a public health problem. So some people use the term police brutality because of the nature of the violence that is being enacted upon the community. But some people use it because it is operating within a domain itself where you don't have an accountability structure, right? So things like this continue to happen. You have increases in the number of people being reported at hospitals who say that they've been assaulted by basically a police officer. Men, okay, and women, but less so women, at the same time that all assaults are actually going down. So why would this happen if we see here a reduction in violent crime and property crime? Why would police be becoming more violent when people are becoming less violent? The community itself is becoming less violent, all right? During this time period, when you see a spike in stop and frisk, this is 2011. This was a court case that actually led to this decline. Okay, they said stop and frisk was unconstitutional, but even still, there was no changes in the racial distribution of those who were stopped and frisked. And this continues on into 2013, 2014, 2015, so on and so forth. So we have a public health problem. People might argue we have a problem of ethics, what people should be doing, but we also have a problem of health, of morbidity. People are being harmed, all right? So what I do in my data is look into a data set called New York City Stop, Question, and Frisk Database. It's basically a data set that's created from reports of any pedestrian stop, and it does have to be a pedestrian stop, so it's not vehicle stops. It can be inside or outside, it can be any time of day, but anytime a New York Police Department officer stops someone on the street, they have to fill out something called a UF-250. All right, the UF-250 was brought into our lexicon in the late 90s after a series of lawsuits by NYCLU. And it said that we need to be able to know what they're doing. We want to know what they're doing, okay? What I find in this data set, just at a basic level, when you characterize or classify these stops by the neighborhood they are in, and these are very large neighborhoods, they're really more like community areas. If you make the comparisons to Chicago, we have about 29 stops for 100 residents. About half of those stops have some kind of pat down or what they call a frisk, and about a fifth of those stops involve one of 9 indicators of use of force. Now, unfortunately, not only do we have a concentration or over-concentration of Black and Latinos who are stopped by the police, but what happens to them when they're stopped is actually very disparate as well. So they're 6 times more likely to be stopped by the police, showing up here, and they're 25% more likely to have frisking and 28% more likely to have use of force compared to their white counterparts. And these are usually neighborhood level indicators, but they flow well to the individual level as well. What I found in one of the first studies that I published was that if you lived in a neighborhood where, let's go back so you can still know what we're looking at, where this measure, right, was 10% more. So you went from 25% increase, well, let's go back. Let's go here. 55% or 54% increase, a neighborhood has 54% of those stops involving frisk, but then you added 9, right? So it went up to maybe 63%. Now you actually could have started anywhere along this, but what you're doing is you're comparing neighborhoods that have a difference of 9 or 10% or more in the use of frisking in the stops, all right? You go from 21% to 29, 30%, or 55% to 64%, doesn't matter. Unfortunately, we linearize that in a way. But anytime you had that standard deviation increase in frisking, you had a comparable and sometimes more increase in the likelihood of that individual in the neighborhood having a health problem, a morbidity problem. And this is comparison to those neighborhoods where they had that 9% reduction, right? Whatever that 9% reduction is. Now, if you're a person who does the public health thing at any level, you might have seen numbers that say, when do we consider it a public health problem? Usually we consider the health problem around 5%. So if something happens to someone and it results in a 5% increase in disease, we consider that a public health problem. We start to be concerned, okay? We have numbers way above that. This is the 5% level, all right? So we have about a 9% increase in saying that your health is poor or fair, 11.5% increase in having diabetes, 12 or 17% here in saying in having high blood pressure, which is huge, all right? And there are actually some emotional correlates of that suggests that we are really running scared from the police, everybody. These are not people who are incarcerated. These are not people who have records. These are people who are living their lives in New York City, and we happen to call them one day and ask them some stuff, all right? We have 15% increase in asthma. The asthma thing comes up again. This is asthma episodes within the last year. And we have a 22% increase in being overweight or obese. Some of these numbers are some very robust to any indicator of stop, push, and frisk that we use. Some of them are actually very particularized. So we find in that study, the one that was published in the Journal of Urban Health, blacks had higher rates of high blood pressure in high stop neighborhoods, in neighborhoods where there was large racial disparities. In frisking, we're at 25%, it was actually maybe 40%, or so on and so forth. Latinos also had higher rates of high blood pressure and high frisk and high use of force neighborhoods. And Asian Pacific Islanders who actually have a lower rate of being stopped at all overall. They also have a lower likelihood of having frisking or force used against them. Even these individuals had worse health, or considered their health to be worse if they lived in neighborhoods where minorities, blacks, and Latinos were more likely to have use of force compared to their white counterparts. In the second study that ended up coming out in social science and medicine, we found that there was a particularized indicator for psychological distress. There was a 21% increase in the non-specific stress overall, or clinical levels of non-specific psychological distress for men compared to women in that same neighborhood. If they had higher levels of use of force in that neighborhood, there was a 13% increase in nervousness and feeling like every day was an effort, and everything and every day was an effort. And unfortunately, there was an 18% increase in feeling as if you were worthless. Now these are men compared to women in the same neighborhoods. There were some main effects of use of force and frisking as well, but these were pretty strong. This one I'll kind of go into. What time do we have? I'll make sure we have time for questions.
20 minutes.
Oh, okay, we have time. So we're gonna go. I'm gonna go for another about 10 minutes or so we have some time for your questions. Maybe even 7 minutes if you get me responsible with my time. But this is a study that just came out in sociological form, and it's showing a kind of a contingency, not of the individual, all right, not the race of the individual, but the race of the neighborhood, right? So with this, there's a lot of stuff going on here. You can read the paper, but the left side basically says that the more minorities that live in the neighborhood, blacks and Latinos, it increases the effect of use of force, main levels of use of force, so percent use of force. On the left side in figure 2, it says actually a very opposite story, but it's also a different construct. The construct here is racial differences in use of force. And what it suggests is that the highest indicators of disease, poor health, diabetes, high blood pressure, obesity, are not in predominantly black neighborhoods where there's a large racial difference in use of force, or there's a targeting of minorities versus whites, but we're in predominantly white neighborhoods. So in predominantly white neighborhoods where minorities are picked up off the street and targeted and say, hey, do you live here? Are you sure that you live here? Wait a minute, I don't know if you live here. I see them IDs, but let me follow you to your house. Wait a minute, let me take you down to the station and verify some things, because you could have stole someone's ID. When things like that happen, not just the black folks who barely live in the neighborhood, by the way, the Latinos, the indigenous people, but the white folks in those neighborhoods also have high rates of illness. It's a system, okay? We have, I'm gonna hold this, I'm gonna show this in a different way, and unfortunately less, more disturbing results or associations. But what I have found over and over again, is it's not, yes, minorities and men do suffer more. They do have particularized hypersensitivities to surveillance, in the neighborhoods where that is occurring at a concentrated rate or an inequitable rate. But we also find, which is much more disturbing, which makes the argument that this really is a public health problem. It's really a societal problem. It's a systemic problem. Is that people who are not in those categories that are targeted for surveillance, they also suffer when surveillance is the mode of operation for criminal justice and policing the community. All right? So when we decide that the way we're going to deal with uncertainty, to deal with the suspects, is to call up someone or send a bunch of units out at certain times, when we make that decision as a society, it's not just the people who get caught up in that structure that suffer, it's you too. When you make that decision, you also suffer. That's what this analysis shows. We're looking at here a much more fatal, and we'll end here where we're going, but a much more fatal indicator of policing, which is legal intervention deaths. So this is actually being pulled from the National Vital Statistics Survey. There are other ways to capture legal intervention deaths. There's actually a data set out now called Fatal Encounter Survey, which is actually much better at identifying things. The Guardian had the Counted Survey. So this is actually really bad. This is one of the least, it shows the lowest number of legal intervention deaths. These are basically when a coroner or a medical examiner says, wait a minute, I don't know why he died, why that man died, except the police got him. The police got him. It had to be the police. They didn't walk into traffic. They didn't put their hands up with the gun inside of it. That's called suicide. That's what it's called. There's a curve for that. There's a classification for this. This is when there's no other reason except for the police got him. Now it could be a gun, it could be a knife, it could be a banging on the head, it could be a Freddie Gray, it could be a lot of things, but it was the police. All right, what we know is that if you live in a neighborhood within a 10-year period, there were more than 2 legal intervention deaths, 2. We're talking about a very low level. That collective memory is very long. For people where this is happening, it's very long. We see higher levels of illness, all kinds of illness. Self-rated health, diabetes, high blood pressure, asthma, even asthma, good gosh, and obesity. Now you can clean these numbers a lot of different ways. I'm going to clean them, 1, by based off the individual composition of the neighborhood. We'll clean them, 2, by the neighborhood composition, which is like robbery complaints, like poverty, we will actually clean them for racial composition. There's one more in there I'm forgetting, it'll come up. But we can clean them in a lot of different ways to see whether the differences between these bars is accounted for by who's in the neighborhood, the demographic profile of the neighbors, or the demographic profile of the community at large. And when you do it, in the end, it doesn't matter, it's still there. It does go down a little bit, the differences, but it's still there. So when you control for individual characteristics, you still see higher levels of most of the illnesses. When you put in both individual characteristics and neighborhood characteristics, you still see higher levels of obesity, and this one is not significant of asthma, but this is a huge difference right here. And this suggests that most of the differences you see in the illness effects of legal intervention deaths are because of the community characteristics, right? It's because of what's actually going on in the community and the characteristics of the community at the aggregate level, not of the people themselves, all right? Unfortunately, we do not get this relief so much necessarily for when women is a weaker reduction, so that women actually remain, it's much lower. So this is, you're happy right now, all right? You're happy right now. You're like, wow, this is horrible, this is really bad. 32% increase in high blood pressure for women once you account for individual characteristics. The neighborhoods are killing them. They're killing them, all right? Or they're making them very morbid and they end up getting diseases that didn't kill them, all right? However you want to tell the story, all right? But here you still see a 7% increase. Once you put all correlates, and you see an 11% increase in obesity. One of the most strongest correlates of police violence that I've seen is obesity, which is a precursor to all kinds of other problems, all right? Now, men actually have a better story. They actually, at the basic level, are not having higher levels of illness, except for asthma episodes, And once you account for the neighborhood characteristics, their risk factors go all the way down. All right? So what I'm gonna do and show you in this last picture is a comparison between men and women. We're looking at the disparity in illness between men and women. This is a gender risk ratio, we sometimes call it. A gender risk ratio that one is attributable to only the neighborhood. That's a lot. All right, so the difference between men and women, let me go back. This difference here and here is not an artifact of individual characteristics. It's not because of the biology of the woman, right? Unfortunately, however, it's also not because of the neighborhoods they live in. So the different reactivity of men and women to legal intervention deaths is not an artifact of either things that women are more likely to, social statuses they're more likely to occupy, or the types of neighborhoods they're more likely to move into. That's the way we can interpret that, right? So it's not because they live in poor neighborhoods, or they live with their husbands, or they live with da 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 da. That's not it, all right? Once you account for these factors, there's still a 14% increase compared to women, to men in the risk of poor fair health, 51% increase. These numbers are just horrible. They're really horrible. I don't like to use the term horrible for things, but this unfortunately is one of those times where it is fitting. A 51% increase in the risk of diabetes compared to men in legal intervention density neighborhoods. 31% increase in high blood pressure, really not a good thing there either. 9% for asthma, and unfortunately a 46% for obesity. I'm going to open it up to questions now. I just want to sit with this picture here. There's a lot of theories we can talk about. I don't think you're really interested in theories. There's a lot of policies that we can talk about. Maybe you're interested in policies, right? But there's also a lot of things we have to do next, right? And we can talk about all of those things.
Thank you.
Like the mental health conditions such as depression,
PTSD.
bipolar, PTSD.
Yeah, we don't have the good stuff. Not in this data set. We have what they call the Kessler. You ever heard of Ron Kessler?
Mm-hmm.
We have the Kessler 6, which is, there was some numbers I showed for that. That's the social science and medicine piece. There's a paper that I'm running around with Tiffany Joseph, where we look at the clinical distress level. So clinical distress it doesn't tell you whether you have depression or bipolar or anxiety. It just says you're stressed out and you possibly have some clinical disease. You still have to go and do the questionnaires for what that is. Philadelphia has it has a longer non-specific psychological distress measure. It also has, that's what it is, yes. We have, I do think it's more like mental health disabilities, or whether your mental health has interfered with you from work or school. It also has whether you've taken any mental health medications. So one paper is on race and immigration enclaves, and then another paper that's kind of weird, but it basically looks at whether, and it's kind of intersectional way of thinking about whether minority men are hyper-targeted or minority women are not protected, shall we say, from the police state compared to white men and white women. And that those have one whole table that's just mental health, and it has like 6 or 7. But it's not the clinical indicators. It's more of the like mental health care stuff.
Right, and I was asking that question because I'm just concerned on if you're being targeted in a particular area and you're constantly, being stopped and frisked, what does that do to your mental psyche? It has to have some type of effect.
I mean, we do know it does. I don't know if I brought it up here. Let me see. No, it's not going that far. But this one, so the 3 that tend to pop up are nervousness. All this stuff makes so much sense at a social psychological level, right? I'm nervous that the police is gonna come and get me. I'm trying to get out of the neighborhood, but I gotta go through 20 different stops before I get there. And by the time they knock me up, sometimes you find work from Nikki Jones, where these boys are being reported. They're reporting sexual assault, right? They're being fondled by these police officers. I don't feel like I'm worth anything. So I asked the question: is this a psychiatric issue, or a psychological issue, or is it a social issue? Because I read this, and there are sadness, helplessness, And another one or the other, they don't pop. Sadness don't pop. Helplessness doesn't pop. Nervousness, effortfulness, worthlessness. That to me sounds social. So sometimes, and I'm a mental health, one of my things is mental health. But I do question sometimes when we look at emotional responses or emotional explanations, whether we're just talking about pathways or pathways to something else. And I'm not saying that the physical health stuff is the only thing that matters, because if you don't feel worth anything, what do you do when you go out on the street? You might throw that gun up, right? You might eat that really nice, I'm thinking about it right now, Philly cheesesteak is very nice. You know, you might do a lot of things, and James Jackson says we're on this stuff, the things we do when we don't care about our bodies. All right, so, but I do wonder whether they're so separate as psychiatric versus, which is the more bipolar, depressive thing. There is a survey also that, National Survey, it goes back sometimes, National Survey of American Life, that does have those outcomes, but it has very generic measures of police, of stop, question, and frisk. Another question here. I saw one. Oh, okay. Take the mic, take the mic.
So, here in Chicago, we spend about 40% of our city corporate fund on policing, $4 million every day, $1.4 billion a year. That doesn't count all the, use cases that go to court and, they borrow money for that. So, every time, not every time necessarily, but like frequently, let's say, there's a spike in violence in Chicago, a bad weekend. They announce more cops, or they say they're going to put more people on beat, or whatever. What do you, I guess, and that's why, there's this approach of politicians to focus on policing as a solution to all kinds of malaise. What are your thoughts on how we push back against the idea that policing is the solution to all kinds of problems we have in society?
So, from what I know, and I don't know a lot, but I do know some things, the only way you push back on it is to create a different system. And you have to create that from the block level. You can't create that at the politician's office. They're not listening. And they're not interested in putting the money that way. They're not interested in taking your tax dollars and putting it on the block to people who actually know who is the problem and who is the solution to all the issues that are going on in the community. There are people who know these things. Now, some people call that community policing, but I actually think that's a bad language that has been co-opted by the wrong people, right? It's not community policing, all right? Because it's not policing. It's taking care of your people, all right? So there are people in Chicago that do that. Definitely on the South Side. There's people in Atlanta that do that. And in DC, there's a lot of people who are on the ground doing block level work, and a lot of it is about connecting people who know things, all right? Sometimes this system can be, it can be facilitated in a way where it provides information to state-sanctioned officers to solve problems that they need to solve. But they're not the same. They're not the same systems. And they don't operate on the same types of knowledge. They don't operate on the same types of social emotions. And a social emotion is something like trust. Like, I think this person will help me when I have a problem. Like, I don't think they'll tell my secrets. Like, what's a HIPAA? We don't even do HIPAA over here. We just don't talk. Now, y'all call it one thing, but maybe we just call it, I think this is someone I can talk to about a problem that I don't know who else to talk to about. So there are, the solution is at the ground level, it's at the block level, and it's getting to know your neighbors, but it's not just that. It's getting to know the network of neighbors that are around you.
I have one quick comment, but I have one quick question. My quick comment is that when we think about this, I hope we go back further in history than your slide goes. And I think we have a lot to learn about France Fanon and other people that look at colonial reactions. We have a lot to learn from our indigenous community. That's just the science. You've talked about legal intervention deaths, which is like the worst endpoint in the world. Should we be thinking about broader indices of the carceral state? Like, we had a poster session on extra tickets for riding your bike, or having your car impounded and all of a sudden you can't get to your job, and all of these other kind of things that may not be physical confrontation with the police, but nonetheless are the operation of the carceral state in general.
Sometimes we call them legal contact. So this literature is, there got a lot of people in it. Some of them are criminologists. Those of us who are not criminologists, we don't know where to start so much. So we rely on what's there, right? So what you see is replicable data sets, right? Things that, I mean, this is New York City, but I could really do this anywhere because this is a national, this is everybody in the United States, territories, and so on and so forth. There are even reservations in this data set. So, I mean, it really anything on the land, this is not their land, but this is land that they patrol. And you can kind of think about all of our land as land that's patrolled. But what you're looking for in general, we have a problem, Philip Goff talks about it, and Nancy Krieger too, about replicable, and just any systematic assessment of what police do. We pay them a lot of money, and then we say, okay, do what you want to do. And what it means is that it doesn't mean that there's one police data set. It's 3,000 and 300 for every police district, almost for every county for sure, but even under the county sometimes, they all collect data a different way. They all collect different types of data. I was in the U.S. Virgin Islands, loved them, but I had a conversation with the commissioner, who's the big man on campus, and they said, "Oh, we have a police decree." And it was like a explanation, like, "We ain't got no problems. We got a police decree." I'm like, "Do you know what a consent decree is? It means you have a problem." And I had to say that just one time. I didn't have to say it too many times. I wanted to get out, but don't be funny. But the consent decree, so I went and looked at it. It's 100 different statements. So I asked them, how many of these are you actually monitoring for? Oh, so basically you can do whatever you want. Even when the federal government, supposedly that you're underneath, says that you should do 100 of them, you're gonna do 4. You don't have the resources, you don't have the time, you don't have the concern. Right, and I don't blame them for that, but what I do say is that that is happening in every county in the United States. I think almost all the counties should be on the consent decree, but only some of them get there, and so they're the only ones that we know about. So we have a problem with data, and when a data scientist looks at a data problem, I start thinking about, okay, I need to replicate it. All right, I need to be able to extend it a little bit beyond where we are, but it can't go too far. So there is a data set that has been collected that I was involved in. It was a collection of us that came together. It's called a Collaborative Multi-Ethnic Political Survey. It's a post-election survey from 2016. And it asks what I would say probably some of the most comprehensive questions about legal contact, any form of legal contact, which the bike ticket, right? The fees, the fines, all the stuff that came out of Ferguson. It asks so many different questions. It's probably about 25 questions overall. But it's asking it to over 10,000 people, all right? A quarter of each which are Black, Latino, Asian, and white. So you have the numbers to actually, they're in national representative samples of each of them. You have the numbers to actually pull apart exposure rates, right? The National Survey of American Life has some of this stuff, but it's Afro-Caribbean and African-American survey in 2002, 2001, and 2003. And the problem there, what you have is that it's just not that many questions. It's like 6, right? All right. And we know that things have been happening over the 21st century. So you're right. And I'm going to go back to the comment you made about bringing in colonial understandings of, I would say, our positionality to the legal system. One thing I know that I do use in my work is a concept called hypermarginality, which is not what you think it is, but it's like a conversation between intersectionality of status and intersectionality of context. So every place isn't just marginalized by class, right? It's like, okay, it's class, and then there's a landfill there, and then we don't get no votes, right? And then sometimes when the water come down a certain way in the summertime, all of our stuff gets burnt up, right? Now there's a lot of stuff going in there, but what do you call that? I call it intersectionality, but not of race, class, gender, sexuality, politics, age, but of place, right? And hypermarginality, this is something that indigenous scholars have. Lucas Brasier is probably one of the better known scholars in this, and we fight with him about some things, but this idea that when people are disadvantaged in in the statuses that they occupy, and in the places that they go home to sleep, eat, play, and get free in, you're creating some form of a cascade of risk, right? That you're not able to just walk out of by getting over one of those issues of inequality, right? But it's really it's something that's it comes from the settler colonialism tradition. It also comes from the post-colonialism tradition, the more global colonial tradition. And one of the at least for me, the challenges is that as anthropologists that are having this conversation, so when they talk, they write the stories. So figure, I got, okay, how do I put this in a state of command? But yeah, room for maybe one more? Sure. Okay.
Thank you for your talk. It was, really illuminating. I wanted to know, when you're modeling, the effect of incarceration on all these health effects, as well as secondary context, family, neighborhood, you're kind of looking at whether they were incarcerated or not, or the individual was incarcerated or not. But how does the length of incarceration affect all these effects on health?
So I actually don't look at incarceration like that at all. I actually don't have a study where we are looking at even neighborhood incarceration. And there's some reasons for that. It's mostly methodological. But the larger question of duration of exposure, I take it. So what I am looking at is, let me show you how to describe this. All right. So Hyde Park. How many times in Hyde Park are you likely to get stopped versus the Chicago loop? That's the difference I'm looking at. Not whether you get stopped in the Chicago loop or Hyde Park, but whether the people of Hyde Park and the people, right, they're likely to get stopped or not, which is a little different than what you're talking about. But it's just your duration of like how often are you exposed to that is a little harder to get at. I will tell you, I know what people have tried to do with this, which is to take the data set, which is fielded every year. Not really fielded, but it's reported every year. And they've tried to create these temporal growth curves of surveillance. The problem is the growth curves are happening, you can actually know this stuff every day, right? So there is a seasonality to this. And there is even within a week, you're more likely to be stopped at certain times. So then how do you create those time curves? One of the ones I did show you up front was the up until 2011. And then it dropped. So this is actually what we're really studying, stop and frisk. So people are trying to take this increase to see whether places that were more likely to increase have more problems. The problem is everybody's increasing at a really high rate. The response to this is, one, is systemic. The second response to that is that when you are concerned about how long an individual is exposed to something, you have to know where that individual is at every time point before they've been studied. Now, most of the best questions we have on residential mobility is, have you lived in a place for 5 years or more? But we don't ask you where they lived before that. We don't tell you which neighborhood, which zip code, which latitude, longitude point did you live in before. There are some good studies of, they call them geographical mobility, coming out of the South, because we have some problems there. But that's actually the problem with studying gentrification. Because if you want to study gentrification, you can't just study the people who are moving in. You have to study the people who are moving out. And you have to care enough to find them. And most of us don't care. As data people, we don't care about the people who are leaving. We just focus on the place that is moving, that is shifting, which is a problem. I'll stop there. All right.
Thank you so much.